I'm Dr. Derek Lee. I'm very happy to introduce a man who I consider to be the top orthotist in North America. He's a past president of SoSort. He's been practicing for many years with vast experience. I know he has over 5,000 patients who he's braced with a 90% success rate. I'd like to introduce Luke Stikeleather. Welcome, Luke.
Thanks, Derek. Appreciate the opportunity to join you and your kindness and the introduction. Thank you.
Oh, it's all true. So transparency as well. I would like to say that I brought my son just over a year ago from Toronto all the way down to Virginia just to see Luke, and I'm just totally impressed with his facilities and his degree of knowledge. And I thought, who better to spread education on bracing for scoliosis than Luke? Having said that, there's lots of misinformation and disinformation regarding bracing for scoliosis. Everything from types of brace to types of curves, etc. So why don't we start off a little bit? The first thing I want to talk about is, I have a list of questions here, Luke. When a parent comes into your office and brings in their child, what is your thought process in terms of what do you look for right away? Because even with my practice, when someone comes into my office, I'm already thinking down my checklist of what I need to do and what I'm seeing and what I'm trying to predict in the future.
Sure. Most of the patients that come to us come by referral from someone, a physician, a chiropractor, a nurse, another family. Most of them I have either talked to or my staff has talked to before they arrive. And so we already have established that there's likely a scoliosis. We may have even gotten x-rays and the documents that we need. And in some cases, I'll even have conversations, particularly with the out-of-town families, because I in no way want them to spend the time, effort, and expense to come without us having at least determined in advance that it's a patient that we could do something to help, and that we've helped those families kind of know the logistics, the lay of the land before they arrive. So when they get here, I already have some sense of what's happening with that individual, but the clinical exam is really important as well. So once I'm in the room with them, I really work at just building a relationship and rapport if I haven't already had that opportunity over the phone, asking questions about them and just getting to know them, putting them at ease so that we can then move towards the actual evaluation and assessment of their person, of their body, of their x-ray. We're not treating an x-ray, we're really treating that individual, and we really have a holistic approach. So all of this goes together in terms of trying to really establish the greater connection with that family and with that individual. That's a little bit of a generic answer. If you want specifics, we can go there too.
Sure, specifics, but I did want to throw in that with my experience as well down at your Virginia facility, I was really surprised at how much time you took to connect with my son. I felt like I should just leave the room because you're just talking to him completely, which is perfect.
You know, I got some really good advice whenever I was first getting in the field a long time ago, and that was from a colleague, an older colleague, and he said, you know, remember who your patient is. It's the child. It's not, when you're dealing with pediatrics, it's not the parents. And the parents often want to speak for the child and they want to know, but look at the child and focus on that individual, no matter what their age, and connect with them. Don't leave them out of the conversation. And it's so true. I really am so thankful every day for my background and training as an undergraduate in social work, for my work in family counseling and in the court system prior to making a career change into this field, because it really serves me every day in being able to remind myself of the importance of connecting and of the relationship element that I feel often is missed in medicine. In the hurry and scurry, and if this COVID thing has had any impact, perhaps it's that we're taking more time with family members and to live life and to enjoy it. And so I recognize that scoliosis is a journey, and in most cases, these families need a tour guide. They need the adventure guide to get them from here to the destination safely, and with education, knowledge, and empowerment. And that often doesn't happen anywhere else.
So true. I was really pleasantly surprised, and I'm sure it helps with, once the young person understands what you're talking about and they're more engaged, it's probably easier for compliance as well to a certain degree.
Absolutely.
Yeah.
Yeah, there's definitely a strategy involved in that as well, because we know that there is a power of that relationship, that if we don't have that connection with them, they're less likely to do a good job with the brace. And we can go there in other realms, but back to your initial question, the actual assessment, I'm looking first at the patient, looking at body imbalances that are obvious clinically, shoulder imbalances, waist asymmetries, doing the forward Adams bend test to check for rotation, using a scoliometer to assess rotation values. That all gives us information as to how significant the curve is, how significant the rotation is, if there's a decompensation or imbalance where the head is shifted off center from the pelvis,
Mhm.
so that we can factor all of that into our brace design. And then we look at the x-ray and we try to explain the x-ray to the patient and family so that we're all on the same page with that.
Did you make a decision very early on in building your two facilities to bring the EOS X-ray facilities in?
Yeah, I encountered that technology, I guess, whenever it first came out. And it just seemed to me, when you're dealing with particularly children who are going to have multiple exams and x-rays over the course of their care and treatment, that you want to have the least amount of radiation exposure possible, in addition to just getting an excellent quality x-ray.
Mhm.
I, over the years, was so dependent upon having patients bring x-rays, and sometimes they'd show up and they had forgotten them, or the quality of the x-ray was so poor that it really wasn't an option. And we had made that change from the old standard x-ray film to the new digital age, but there was still issues. So it seemed to me that if we were going to have a comprehensive center of excellence, that we really needed to go all out with technology to assist us with that and to serve our patients. And I attempted to do some partner relationships with some local hospital entities, but the technology was so new and particularly expensive that I couldn't get them to get on board. But everybody's starting to really recognize the value of the EOS system.
Absolutely. And and for out-of-towners, especially,
Yes.
the 24-hour turnover for a brace, including the x-rays and the fitting, is, especially coming from Toronto where I am, where it could take 3 months to see a specialist and another month at least, or 2 to get a brace done and fitted. And time is often not on your side with the bracing.
Yeah,
Scoliosis progression.
exactly. You're absolutely right. So the sooner we can get moving and getting into a brace, the more likely we are to have a successful outcome and maybe even improvement with that. And yes, as a complete center, having the EOS and having brace capacity, making that on site really enables us to do these same day turnarounds, which frankly, I think should be a model that others emulate. And we're certainly attempting to help others as we mentor people around the country, but no one else seems to really have grasped the importance of that. And I just think the beauty of one of those elements of being able to make it on site is to be able to get the patient and family involved in making their own brace, which is a lot of fun for them. And I think it adds one more dimension to the buy-in for compliance.
Absolutely. It was another surprise was having my son follow you into your manufacturing lab and actually help out with making his own brace. Is that part of your social work training as well, that you try to engage that way?
Yeah, I think so. I don't think that the social work ever had any knowledge that I would become an orthotist and to kind of take this track, but I draw again from that experience and just saying, what is it that's going to make a difference for this individual? We recognize that universally, globally, children, teenagers in particular, have concerns about their appearance, probably as one of their highest priorities, and secondarily, their comfort. So if I can resolve comfort issues and if I can get a brace that looks good and fits well under their clothing, and most importantly, functions well, then I'm much more likely to have a successful outcome. And part of that relationship and making them comfortable is bringing them in the lab and letting them see how it's made and having some ownership for participating with it.
Makes complete sense. Now, if we go back to some general bracing questions then, what are the goals of bracing in terms of scoliosis? I know it's a huge question, but if you'd
Yeah,
like me to break it down, I can.
no, I think it's pretty straightforward, and we can just answer that very simply. Number one goal is to prevent curves from progressing to surgery. We want to, we all know, and I think the orthopedic community would acknowledge now more than ever that the literature is there, that if we can stop a child from needing to have instrumentation, their quality of life will be much better off. There are absolutely those cases where bracing is not the best option. High degree of curvatures, significant changes in appearance factors, and surgery really is a necessity, and it's the right choice. But if we can prevent that, that's certainly our highest priority. So the number one goal is preventing curve progression. If possible, we'd like to even see if we can get the curves reduced, bring curves down, because we know that curves less than 30 degrees are more likely to have stability long term. They're not likely to progress through the seasons of life, as I call it. So as we age and mature and we're susceptible to the forces of change and gravity, they're less likely to be problematic. So smaller curves are better in general.
In your practice, where do you see, at what stage do you usually see kids for bracing?
So in our case, we see infants all the way to the geriatric population. If you think of the bell-shaped curve, the preponderance of our patients fall in that 5 to 15-year-old category. That's the ones that have curves that have been established and progressed. But certainly there is a small population of young children in the infant to 3-year-old category, and there are the adults who are dealing with pain-related issues and quality of life stuff that benefit from being braced as well.
Okay. Have you found that there's generally a type of curve that responds in terms of AIS best to bracing in general, or it just kind of depends on so many variables?
Oh, there are so many variables, actually, Dr. Lee, that it really depends on that individual. And the real puzzle is, what's the combination of Cobb angle measurement, rotation in the spine, decompensation, flexibility, any underlying issues? So AIS ends up being that catch-all category that hasn't been figured out as something else, as an underlying causation. But I think there probably are a number of hypermobility, connective tissue issues that might be falling into the AIS category. Mm-hmm. So you get some children who have more inherent flexibility and mobility in their spine that really get good corrections, and then you get those children who've got a little bit more stiffness to them. So in general, the easiest curves for us to manage and deal with are going to be, number one, smaller curves in that range between 20 and 35 as preferable, single curves over double curves. The physics is such that you can actually move the spine with longer lever arms. So if we have a single thoracic curve, we've got more opportunity to spread out the force loads and to get a nice correction there than we do if we have a two curve, a thoracic lumbar curve, or if we have a triple curve pattern.
Yes. I guess it helps that you've seen some must be close to probably, 5,300 patients. Do you have a tally going on, or?
No, I gave up on that a long time ago. My sister and I, she's a nurse midwife and she delivers babies, and we used to have a competition to see if I had seen more scolies or she delivered more babies, but we kind of lost count.
I guess it blurs together after a while.
Yeah.
Why is it important to brace when a child is growing?
I like to say that there are three primary factors that impact having scoliosis and its likelihood for progression. So I call them the 3 Gs. Growth is the second of those two, and growth is a very dynamic force. We see it in nature all the time in terms of the impact of weather on trees and why we guide trees to hold them in place as they're saplings and are growing. So when you have an individual who's young with a lot of growth potential and they develop scoliosis, that accelerated growth that happens primarily in these growth spurts tends to really make these curves progress and change. The reason that girls tend to have a higher incidence of treatable scoliosis and surgeries over boys is that because they tend to grow differently. They go through these rapid growth spurts, and this rapid growth tends to make that curve increase. So catching those curves before the growth spurts or during the growth spurts and kind of providing an external body support that guides their growth is a critically important timeline.
Okay. And I assume you, with the growth spurts and the growing in general, you take advantage of growth modulation as well, the vertebra?
Growth modulation is certainly a concept that we are promoting as an opportunity to improve curves. And it's a dynamic of growth that is important. If we can do that when we're bracing, if they're growing while we're bracing, then we can, in probably 30% of our patients, see long-term improvement. The concept that's evident in tethering is also depending upon this concept of growth modulation. So it's the power, the dynamic force of growth, it actually changes when you apply either internal or external constraints that direct the growth.
Yes, it's pretty fascinating theory, and I guess I've always thought that you know, tethering, bracing, very similar in terms of its goals in terms of growth modulation. In brace, trying to get as close as best correction as you can, and seeing how the vertebrae change.
If I can add to that real quickly, Dr. Lee, what I see is that when the brace goes on, the curve comes down. We take an in-brace X-ray, and that is what we're looking for as evidence that the brace is working properly. And so getting an in-brace film shortly after a brace has been applied, ideally within 2 to 4 weeks, because that gives time for viscoelastic change. Soft tissue responds to loads placed on it. And so over the course of several weeks of getting used to the brace and wearing it, you'll get a little bit more dynamic shift and change than you initially in 24 hours, which unfortunately we have to do when we have the out-of-town families. And so the in-brace X-ray gives us some sense of how the spine is responding, and it's a critical feedback element to me and to our team to know how to adjust the brace and make changes to get the optimal in-brace change correction. And it's a predictive value for what the long-term is going to be as well. So I don't want to pass over that comment before we move on to another question.
No, it's fine. And since we're on in-brace X-rays, there seems to be quite a diversity in length of time between fitting the brace and looking at an in-brace X-ray to confirm. From some surgeons I know, it could be you know, a couple of weeks to like 4 months. What do you think is too long, or in terms of too long a period to wait for an in-brace X-ray? Because I'm figuring, you know, 3 or 4 months later, you have no idea what's going on over that period of time.
Yeah, really important question. And I think that it goes to the issue of a need for a more universal protocol in scoliosis management, something that I certainly am an advocate of, and that SOSORT has tried to provide some guidelines for, and we have been part of a consensus group that has attempted to provide some direction for professionals across the full spectrum. Because everybody seems to have their own little program or protocol, and it seems to be dependent upon whoever is at the hierarchy calling the shots for that patient's care. So unfortunately, based on where an individual has been trained and what their value or belief system is, will determine what happens in that case. So when we have the opportunity, we certainly like to try to team and collaborate with the physician who's involved in recommending what we think is an ideal protocol. And from our standpoint, that would be that they come back and see us weeks after the fitting of the brace, if they're on the local level and can do that, that we make adjustments, and either that day or within the next 2 weeks, they see the physician and get the in-brace X-ray. We need immediate feedback. And so within 4 weeks, we've got that. so that we can make changes and adjustments to the brace in case it's not getting the correction level that it should be getting. When we go longer, when we've gone 2 months, 3 months, you've lost a window of opportunity there to really optimize the function of that brace. And it's not problematic in the sense that you can still make changes, but it's not certainly ideal.
Mm-hmm.
So I think the feedback loop has to be within 4 weeks,
Okay.
as much as possible.
Now, in terms of in-brace correction, it seems that 50% seems to be almost the standard outcome or prediction in terms of whether brace is effective or not. Is that the case?
Well, it certainly has been something that has been promoted for some reason amongst physicians. And there is this myth that 50% is necessary. Some research done at Texas Scottish Rite Hospital in Dallas indicated that in actuality, 30% in-brace correction was sufficient. So if there's a range in there, and so unfortunately there's been this overemphasis on the Cobb angle value. The Cobb angle is just, from my perspective, one of the variables that we need to be looking at, including the rotation and the compensation, both in the coronal and sagittal planes.
Mm-hmm.
So it's really important to not overemphasize Cobb angle reduction, because in the effort to really squeeze the spine or to squeeze the patient and get better reduction down to the 50% level, you potentially are impacting compliance. You're making the brace more uncomfortable. You potentially are distorting the rib cage and doing damage to both the physical and emotional element for the child. So you have to be careful, and that's why it's, to my mind, the holistic approach of saying mental health is important, physical health is important. The ultimate answer isn't 50% correction, and I can show you examples and cases where we didn't get 50% correction, but by good compliance and remaking the brace every year as the patient grew, over time we still got reduction in the initial curvature. So I really want to dispel this myth that 50% correction is necessary. It is absolutely not. It should not be a goal. If it happens, that's awesome. But the mechanics of the spine don't always allow that.
Okay, I'm glad I asked that, because that was a myth that I thought was an actual fact or a recommendation. Thank you.
It's quite common.
Okay, because I know in my son's case, we were pretty fortunate to get, I would say, almost like a 60% correction with him, and he was kind of stiff in terms of his spine. And that was one question I was going to ask, because you have so much variability in spine stiffness as well, right? But if you try and force it too much, then like you were saying, the child is so uncomfortable. What's the point? Because they're not going to wear it anyway. Since we're on this topic as well, I'm going to, and we're on the page of compliance. What happens if the child, whether it's for cosmetics or comfort reasons or mental health issues, just doesn't want to wear a brace? Have you figured out any kind of methodologies, or what do you do in those cases?
Yeah, there are a lot of variables there as well, Dr. Lee. The family dynamics, the parent-child relationship, whether or not there are other extenuating circumstances domestically in that home. So that's the social worker side of me that tries to parse out those details and figure out, what do we really got going on? Do we have a unique personality with this child, or are there other elements at play? So most kids will at least be willing to wear a brace at nighttime if they don't need to or have to wear it during the daytime, or they're willing to wear it at home. So we try to come up with a program that at least can mitigate the risk for progression. If we can stop the curve from getting worse or slow it down, then we've accomplished something. And if they're willing to wear a brace part-time or nighttime, that's better than no time. It's the kids that just won't wear it at all that are, from our standpoint, more likely to see long-term progression or difficulties. So while on the one hand, we advocate unique to each individual schedule of wear time, we're trying to take into account their unique sensitivities, both physically and emotionally, to figure out what's going to work for them and track that. We try to get them back every 3 months as part of our protocol, so that we have visual and hands-on observational assessment data collection of height, weight changes, brace fit, wearing time.
Okay. Now, if you do have a child who's very compliant, what do you have? What do you suggest in terms of optimal wearing time for being in brace?
So based upon their age, maturity level, growth potential, that will kind of determine that. But when we have, let's say, the run-of-the-mill average in the middle of growing timeline, when we have the opportunity for getting improvement, we also know that that's the prime time for progression as well. So our standard is to recommend 21 hours a day. We have some physicians who recommend 23. We have some that recommend 18. Some who just say, oh, I just only use nighttime braces. At 21 hours, we're giving them an opportunity to have the brace off 3 hours, get a shower, run, jump, play, have some fun, and maybe participate in their sports and activities, with the caveat that on the tournament day or the special event recital day, they can have it off longer. But if we give them a target of 21 and they can get pretty close to that, we're much more likely to, number one, stabilize, and number two, see improvement. So that's our preferred recommendation in most cases. And then we tailor it from there based upon skeletal maturity and other factors. Risk for progression. A low risk curve has a little more latitude than a high risk curve.
Absolutely. Now, I've always been, concerned about muscle atrophy with wearing bracing for so long, and that's why we incorporated Schroth exercises, Cs, that type of thing. And you actually have a Schroth facility within your facility.
Right.
Is that the major reason for that?
Yes, absolutely. I had the good fortune of living around the world as a kid, and I spent a number of years in Europe as a child, and kind of see the world as the bigger picture of having opportunities and things, and being able to listen and learn from others in other places. And so kind of at a point in time when I was frustrated with higher valued curves, girls and guys with 40, 45-degree curves that we braced successfully, but within a year or two after bracing, I learned that they went on to have surgery because either the curves progressed or the physician that they were seeing had recommended that and they didn't see any other options. I started looking for answers, and I discovered those in Europe at a conference when I first learned about the whole Schroth therapy thing. I was somewhat skeptical because in the US, the model had been that physical therapy was really of no value, and that there was no statistical or research science to validate or support that. So I said, if this is going to work, we're going to have to see it in person. So I took patients to Spain and met with Dr. Rigo and got them engaged in 2 weeks of intensive physical therapy as my trial to see whether or not there was really value in this whole Schroth therapy. And at that point in time, Schroth was only in its infancy in the US. One other therapist had just recently started to do this. And from there, over the last 16 years, it's really grown quite significantly. And I think more than ever, we have strong evidence that the combination of Schroth and bracing, or Cs for that matter, but the point being scoliosis specific exercises, different than the average physical therapy that's done in many places, really benefits patients. It really equips them and empowers them to understand their bodies, their spines, their curvatures. So the synergy between bracing and therapy is significant. So we really try to target who's going to benefit most from that and advocate that they pursue that. And interestingly enough, a lot of physicians are overcoming their skepticism about it and are starting to support the recommendation.
Well, I think if more physicians actually had a actually witnessed a Schroth session with a scoliotic patient, they would kind of see right away in terms of the posture corrections what the benefit could be potentially, as opposed to just reading in a research paper
Right,
sometimes.
right.
Now, a question I have is, often parents are, I shouldn't say often, but sometimes parents are disappointed in bracing, and they feel that after their brace is removed, it actually progresses or the curve speeds up. So I have two questions. One is, I tend to believe that with those individuals, the child perhaps wasn't doing any exercises at all. So if there's muscle atrophy and you remove the bracing, there's a lot of slouching going on in terms of there's nothing to hold the curve. I don't know if I'm on the right track or not. Do you have any comment on that?
Um, I think there's certainly value for some patients with the exercise. We really attempt to be selective in that process. We think there needs to be a cognitive development maturity there. That's often around age 12. And so younger children may not be as inclined to do the exercises or be able to do the exercises properly. You'll find amongst the therapists varying viewpoints about that. Some who want to do Schroth therapy on 8-year-olds, but I try to go back to the source. And the source for me, since the original Katarina Schroth clinic, it has changed, such as really Dr. Rigo. But there are other resources on Schroth therapy in the C's. But the key is that you're selective in how often you do it and how intensely you do it and on what size curves you do it. But I think the bottom line is that compliance is a combination of a number of variables. Every child is different in their posture, as you're indicating. And so you really want to assess and equip them with the skills to kind of understand and to do, whether it's the bracing or the therapy, in order to get successful outcomes. There might be a hypermobility factor at work there in some of those curves that are braced, come out of the brace, and then progress. So those are all the elements that really have to be assessed. So I'll stop that because I know this might be answered in another question.
No, it's okay. So in a sense, it's very multifactorial in terms of, because oftentimes I've been reading as well a little bit of research indicating that sometimes bracing is stopped a little bit too soon, because there tends to be, even after the growth spurt stops, there can be a year or two of continued curve progression as well sometimes. In general, when a braced patient's curve has been stopped, hopefully reduced, when is it time to stop bracing? Is there like a Sanders score or anything like that you factor in?
Yeah, that was one of the questions in our consensus group last year, and continues to be somewhat controversial. I think there's growing evidence that we should wait. We should wait until Sanders 8, definitely Risser 5, no question in my mind about that. And from 7 to 8 on the Sanders, from 4.5 to 5 on the Risser, I think nighttime only is probably sufficient. It's all about risk management. And so as growth diminishes, we have less risk for curve progression, particularly in milder curves. What I call high risk curves are those over 40 degrees and approaching that 50, 55 range, when we're probably beyond the scope of bracing in some cases. But risk management means assessing for each individual, when is it appropriate to back off on wearing time.
Okay.
But staying the course, because certainly experience has taught us over the years that prematurely pulling a child out of a brace can have significant consequences. And the contrast is that wearing a brace a little longer may be disappointing to a child, but really isn't in most cases harmful to them.
Okay. Now, what are the next step if a curve continues to grow regardless of bracing?
Yeah, so when we talk about success rates, and we see from the University of Iowa brace study that around a 72% success rate, and from our own experience, higher values approaching 90,
Hmm.
what that says is that when you catch the curve at the right place at the right time, and you've got patient, parent, and team collaborating together and working well, then you're very likely to get a good response. But that doesn't guarantee that everyone is going to have that response. So smaller curve values, better compliance are much more likely to be stable and not progress. Higher curve values are at risk not only because of the growth, but also from gravity. And frankly, not all braces are the same, and that's a big factor here. So as I go around the world, as I interact with colleagues, as I listen and learn from them, and as I share our experience with them, it's quite evident that there's a significant disparity in the quality of care and in the quality of braces that kids are getting. But ideally, you are monitoring and watching, and curves can progress and change while wearing a brace. If you can keep it under the surgical threshold, they may be able to successfully graduate from the whole program and not need to have surgery. But obviously, there is a point in time when we have to look at that factor as well.
Okay. While we're on the topic of different styles of braces and how they've progressed, I guess Dr. Rigo and the Rigo Cheneau style braces, you've been manufacturing those and you've been certified since 2004. Is that correct? Something
Yeah,
like
I
that?
first met him and then kind of started connecting with him, and probably
Mhm.
by 2005 started to implement his principles into the work I was doing.
Previous to that, were you using a standard, more symmetrical Boston style brace?
When I was at Northwestern in Chicago doing my orthotic training, I had the opportunity to go to a scoliosis clinic at the University of Chicago. At the time, it was Dr. Bunch, a Scoliosis Research Society past president and phenomenal guy. And the orthotist that was working with him there and that really mentored me in my early days is a guy named Tom Gavin out of Chicago, still in practice.
Okay.
So I have a debt of gratitude to two guys in particular, Tom Gavin first, and then to Dr. Rigo, amongst other colleagues and peers. But Tom was using with Dr. Bunch the Rosenberger brace. And they were really the only ones in the country doing it. The Rosenberger brace had come from an orthotist named Richard Rosenberger in Charlottesville, Virginia, where Dr. Bunch had been prior to coming back to Chicago.
Mm-hmm.
And the Rosenberger brace opened in the front. It made it easy to get on and off. It really was a 3D brace ahead of its time because at the timeline, typically the other underarm braces most commonly used were the Wilmington brace or the Boston brace. So my early exposure and experience was exclusively with the Rosenberger in training, though I did work for an orthotist for a short period of time who used a Wilmington brace. And from my perspective, there's just night and day differences in brace design between Rosenberger and Wilmington and Boston, and then even further taking it to the next level into what we're doing with the Rigo Cheneau style.
Okay. Can you go into detail a little bit more about that and what's the big difference between more of the symmetrical versus asymmetrical, I guess?
Right. In 2004 or 5, we had a conference in Barcelona where I met Dr. Rigo, and then I got involved with those guys, and we put out a first consensus paper. And the whole emphasis was trying to get a sense for, do we understand where to push and how much to push and why to push on spines in order to get movement and get correction. It was quite evident from the different responses coming in our survey that it was all over the map. People had different ideas and approaches to how they were going to get a reduction of curves with the brace. There were as many different brace designs, frankly, as there were individuals participating in the survey, and everyone somewhat kind of nationalistically attached to what they were doing. So our whole focus was to kind of enlighten each other as to what was going on and was there a better approach? Could we incorporate concepts and understanding from biomechanics, from anatomy and physiology that would really instruct us on how to appropriately design a brace, engineer something that optimally moved the spine in all three planes of movement, that change sagittal, coronal, transverse issues. And I'm sure you're going to explain all those terms to your patients as well and those who are watching this. But effectively, how do we design a brace that addresses rotation, addresses the Cobb angle, addresses alignment of head over pelvis, both from front to back and side to side? Mm-hmm. There were very, very few braces that really accomplished that. And so as we have learned more in the evolution of bracing, we recognize that some of the early attempts really were rather two-dimensional. What I mean by that is that they address the X-ray in terms of trying to apply corrective forces to the curves, but really ignored the rotation and the other elements. And so those often were done by squeezing everything very tightly. The initial 2D braces applied forces that got curve correction, but at a cost. And the cost often was patient comfort. The cost often was at impacting the shape of the torso. You could actually deform the torso and make it look like the brace long term. So we called it a stovepipe torso, where there's chest wall deformity. So the significant difference between 2D braces and 3D braces is obviously that a 3D brace is going to be directive forces, where we're applying selective loads to move the spine where we need to move it, with holds opposite those. So if we're applying a corrective load to the side of the thoracic curve, we want to leave a void on the opposite side so that we're not constraining or pushing up against a wall. And in the same way, we can derotate the spine. So if you look, if someone shows you and explains what a 3D versus a 2D brace, it should be pretty evident to see that the design of the brace is such that you can grow, you can breathe, and that you've got the ability to move with inside the brace. You're not locked up.
Absolutely. And when you look at the bird's eye view of the brace, in terms of the symmetrical brace, it's just a sausage, right? Or just a cylinder.
Yeah, exactly.
But with the 3D braces, you see the actual forces that are trying to be applied, which makes sense because the scoliosis is completely asymmetric. So why wouldn't you use a asymmetric brace?
Yes.
I don't know, seems too logical to me, but.
Well, yeah, it is logical when you stop to think about it. And I think as we look across medicine overall, what we see is we see specialization. You know, the nephrologist who deals with kidneys doesn't necessarily know as much about cardiology as the cardiologist does. And you certainly don't go to an orthopedist for brain surgery. But within the realm of orthotics and prosthetics, unfortunately, you have orthotist prosthetists who have a broad depth, a broad breadth of training, but not necessarily depth of training in any specific thing. They're not specialists. And so I've really become an advocate for specialization relative to scoliosis. Let's make people have the level of knowledge and understanding that serves patients best. And let's stop encouraging patients to go to places to get braces when the individual, they are well-intentioned and wants to do the best, really doesn't have the experience or the knowledge to provide that.
And I know one of your passions is trying to teach other orthotists around the world with respect to bracing. Have you found that it is a bit of a struggle in terms of the newer 3D technology, or is that becoming much more popular now?
It's certainly growing as technology opportunities change. It certainly, I think, and as we're publishing more through SoSort and other avenues, there's an awareness, I think, that is growing. And the evidence is there that I think is irrefutable now as a result of the Iowa brace study that bracing is effective. And prior to 2013, when that study was published in the New England Journal of Medicine, you had the ongoing debate amongst mostly orthopedic surgeons as to whether or not bracing was effective. And until that question was conclusively answered, it somewhat was individually variable based upon the opinion of, at the local level, of that physician. And often the physician based their judgments on the quality of the bracing and the results that they were seeing at the local level. And so if you have a well-intentioned orthotist who lacks skill and training, not getting results in patients whose curves, in spite of bracing, are progressing to surgery, then you conclude that bracing was ineffective.
Mm-hmm.
So I think we're across the board raising the bar and the standard of care. And I'm excited about that. I really am hoping that in the next 5, 10, 20 years, that globally speaking, we'll see a much better understanding of scoliosis amongst specialists and practitioners, and we'll see better management for patients and less surgeries.
Okay. Just 2 more questions, Luke, if you have time. Do you know anything about the Providence nighttime brace? There seems to be a little bit of research coming out in terms of it. It might be as effective as some TLSO braces that you wear for longer periods, but just overnight. Do you know anything about that? Just
Absolutely, sure,
Okay.
absolutely. Over the years, we've kind of tried to put together PowerPoint presentations to different seminars and individuals on the history of braces, where they originated, and who designed them, and so we understand Providence pretty well.
Okay.
I've used a number of them in my practice over the years. It is one of several options, nocturnal management braces, nighttime braces, effectively. And the whole focus of that started with patients who weren't willing to wear daytime braces. An orthotist initially on the Charleston bending brace, I think, had his daughter who said, "Dad, I'm not wearing a full-time brace, but if I only had to wear it at night, I probably would." So he came up with a design, and so the nighttime bracing started to catch on. So from the beginning, it wasn't, from my perspective, an optimal brace because it focused on a non-compliant patient. It focused on someone who was willing to wear it sometime, but not all the time. And consequently, you can get some dynamic effect and dramatic changes in the supine posture. When you're lying down, the spine is more relaxed because gravity is not pushing on it from the axial loading downward. And so consequently, the flexibility of the spine is such that you can get some significant reductions of Cobb angle values. And the Providence certainly has the ability to do that. As soon as a patient stands during the daytime or sits and goes through their activities of daily living, you're loading the spine again with a gravity-induced force that causes the curves to pretty much revert again. So you have to be very selective in who you use Providence or other nocturnal type braces for nighttime bracing. And we certainly do that. So smaller curve values, more mature kids near the end of treatment, those are the ones that I think are optimal for nocturnal braces. And I'm not a fan of using it routinely for all patients, nevertheless, because we have physicians who often are directing the course of care and making the recommendations. If it's their belief system that the only brace I use is a nighttime brace and I use the Providence, then that's what the child gets, unfortunately, and thus the parent gets online and starts reading and researching and figuring things out. But when it comes down to just pure mechanics and risk for progression and optimal management of scoliosis, a standard, I'm just using a nighttime brace, isn't ideal. And so you have to be very careful and very selective in who to do that with. And the other element, again, to throw in there is going back to the mental health aspect. Some patients cannot handle wearing a daytime brace. They don't want to go out of the house or into the public or in school with a brace. And maybe that is the best option. And it can be effective in many cases, but it, again, from my perspective, has limitations.
Okay. Now, in terms of the Rigo Cheneau's style of brace, do you think it has well, where do you see it progressing? Because there's always movement in technology going forward. Do you predict any kind of, or can you foresee any advances in bracing over the next few years?
Good question. I think that there are several of us that have really attempted to promote the principles that we've learned and benefited from working with guys like Dr. Rigo and others who really understand the mechanics of scoliosis. And I think that comes through the education and training that is out there and available for those who would avail themselves to it. Unfortunately, there's also a move of others to kind of get on the bandwagon who are wanting to promote their practice and to advertise that they're offering a service when they really haven't invested time or training to become competent at the work. So I can't state enough the importance of competency, of training, of expertise. And I really, really am a proponent of mentoring programs. I really don't like individuals who, for self-service, are advertising and saying that they're doing things that they don't understand and have the ability to do. As far as the future goes, the more we understand, the more we know what we don't know and what we still need to learn. And so I try to maintain a humility and learn from my mistakes and to recognize that there's so much more. So we're working to try to come up with better approaches that can get the more results, better results. Obviously, patients would love no brace at all. And we look for the cure and the magic pill and anything else that could avoid that. But until then, we keep plugging away at trying to make incremental evolutionary changes. Not revolutionary, because I think it takes time. And that's what we see through the history of bracing that's been done for thousands of years, is incremental changes. So I'm hopeful and optimistic. I look forward to being more involved in that in the future. But we need more time and we need more money, frankly. We need research devoted to non-operative advancements. You wouldn't believe the amount of resources that are spent every year going into surgical advances and instrumentation and procedures, but nothing, for the most part, going into non-operative research.
Makes sense. And just to basically repeat what you said before, you know, it's just from my journey through trying to figure out this scoliosis maze. You just increase your chances of doing the right thing or making the right moves by looking for the most experienced, and in terms of practitioners, and the practitioners with the most experience specifically with scoliosis. My experience was not the greatest when I went through what I had to go through with the first surgeon in terms of the type of brace, the brace management, and the lack of options. And that's what kind of lit the fire under me I have to find the most experienced and the individuals with the most expertise, because that's who you have to go to get the best options, right? And that's why I found you, Luke.
Well, and you know, the good news is that you guys are on the right path. You know, if you don't mind me mentioning, is that your son had a little bit more challenge with his curve, not only from the size of it, but also in the sagittal plane, that element of hypokyphosis that really makes it much more difficult to brace effectively for the long haul. So those are those individual factors that I think an orthotist needs to understand and be able to do it. So we weren't successful in keeping him from needing to have a procedure, but the good news is I think he got some benefit from what he did, and it certainly moved you in a direction that you might not have gotten otherwise.
100%. And he, with the bracing and with the Schroth and all those protocols, I believe he got between about 10-15% reduction, which is of the 90% of patients that you see, 60% is stopping of curve progression and 30% is reduction. So he was within that, but I knew that he was approaching his growth spurt at around, I would say, about 47 degrees or so, or 45 degrees. So it was a tough call, but our experience was as terrific as it can be for bracing. Let's put it that way.
Sure.
Okay. All right, Luke, thanks very much for your time. I really appreciate it. Very knowledgeable, and I'm sure my patients and other individuals are going to love the amount of suggestions and the knowledge that you put forward. Thank you very much for your time.
Thank you. Appreciate it, Dr. Lee.
Okay.
Take care.
You too.